Hello everyone, and welcome to this webinar for the Scottish Dementia Research Consortium. I'm Dana Wong and I'm going to be the chair and discussant for this session. We're talking together about a remote management of and assessment of cognitive issues. So we hope to give you some practical tips and learnings from our experience here in Australia. We just want to say thank you also to Terry Quinn, who invited us to give this talk, and Terry does a great job of trying to build bridges across countries and across different areas of practice like stroke and dementia, for example. So we're excited to be able to share what we've learned from our experiences, both in clinical work and research. So here's us. There'll be three main presentations today, and then at the end of the presentations I'll be asking some questions, and we'll be discussing together some common themes across the presentations. So we're going to start with Kerryn Pike, who's going to talk about online and telehealth interventions for older adults. And then Wendy and Rene are both going to talk about a younger onset dementia telehealth project, with Wendy talking about its development and implementation, and then Rene talking about the experience of implementing it. We're going to get started. So first up, we've got Kerryn, who's, as I said, going to talk about her work on online and telehealth cognitive interventions. So I'm going to stop sharing my slides and we'll get Kerryn's up.
Thanks, Dana. I'll just grab them up. Okay, all looking good. Well, thank you. I'm really excited for the opportunity to speak today about my area of clinical and research interest. So I'll be talking about older adults really in the pre-dementia stage. So we're thinking about older adults who have got concerns about their memory and thinking, or who might have actually some mild cognitive impairment. And really what I've been doing, I guess, over my career is working on interventions to assist these older adults with improving their cognitive concerns and giving them better quality of life in everyday life. So I'll be speaking about cognitive interventions that I've been working on for years, but today I'm really just going to focus on a couple of pilots that I was involved in last year, where we got to have a chance to do some remote interventions with people. And I'll be talking about a telehealth intervention, group intervention, and an online memory training intervention as well. So we know there's lots of evidence now that face-to-face memory interventions are effective for older adults, both those who are concerned about their cognition and those with mild cognitive impairment. But one of the things is there's quite a few implementation issues with these face-to-face interventions. They're difficult in terms of getting enough people in the same place at the same time. It's difficult to get enough facilitators trained to have that within your health services, and the access barriers about people who can actually get to the hospital or the clinic where the interventions are being run. And we had those already, and then of course we had the pandemic, and that's made everything even more difficult to have face-to-face group interventions. So as I said, I'm going to talk about two solutions that we tried last year, one a telehealth memory group, LaTCH Telehealth, and then talking about an online training. And I'll have a little bit of a talk about the feasibility, acceptability, and the efficacy of these two pilots. So just to get us all on the same page, so LaTCH just stands for La Trobe University and Caulfield Hospital. It's a memory management group intervention, and it was developed by people at La Trobe University. So that was Emeritus Professor Glinda Kinsella and myself at La Trobe, and together with very experienced clinicians, Liz Mullally and Liz Rand, who both work at Caulfield Hospital. And so we developed this group intervention a number of years ago, and you can see there we've done a bit of research, and it's got quite a good evidence base, and you can go and have a bit of a look at the evidence for this program if you want. Just to give you a bit of a sense, so when it normally runs, so it's usually been a face-to-face group, so it runs as a manualised program for about 6 weeks, 2 hours a week. It was initially designed for people with mild cognitive impairment, and then we extended it to healthy older adults with concerns about their memory in a group format. This is actually a LaTCH group running in the photo there, usually led by an experienced facilitator and a co-facilitator. And it has a semi-structured sort of interactive format. So there's a manual, but the idea is that you can be a bit flexible with the delivery of the information depending on the group's needs. It has a psychoeducation, it has a CBT approach really, with psychoeducation and a bit of therapy, a bit of structure and support for people with their memory concerns. And it's usually run in a fairly low tech kind of way, using whiteboards for brainstorming without sort of PowerPoint, really getting the group to interact. one of the reasons I think LaTCH works so well is because there's a number of behaviour change techniques embedded within the program. So these involve things such as demonstrating, instructing, and then providing greater practice with different memory skills that we're training people in, teaching people a problem-solving approach to approach their memory issues in everyday life, using goal setting, getting people to self-monitor to see how they're going. And we use weekly handouts and assignments to get people so that they're not just coming to the group and interacting at the time and not taking it home. We really want this to be something that people take home into their real life. In terms of the content, so the structure basically follows common everyday complaints. I'm sure if you look at this list of complaints, there'll be things that you think, yes, those are the things my clients talk about all the time. Pretty much one topic is for each week, and we go through and provide strategies on the different topics each week. And then we look at this sort of structure. So we provide them with some models of memory to understand how memory works and how it changes with normal aging, what sorts of things impact memory. And then we talk through a variety of different strategies for addressing memory issues in everyday life. So some of these are about sort of preparing for remembering, giving yourself the best chance to remember by being confident about your memory, paying attention, that sort of thing. We teach them a bunch of strategies that are really about reducing memory load. So, if you don't need to, don't remember it to start off with, do something straight away, use external aids, use organisation. And then we spend some time going through specific memory strategies that have got good research evidence that work. So this is spaced retrieval, association, and implementation intentions. And they tend to do those different practical strategies across a range of different topics. And as I said, we practice within session, we demonstrate them within session, and we get them to practice the strategies within session, and then they take it home for homework and let us know how it goes. So that's a bit of a sense of LaTCH. So this is about the telehealth adaptation. So before last year, we'd been offering LaTCH as a clinical service for older adults through Caulfield Hospital, and that was for both the memory clinic clients, but also some clients through community rehab. And as you may be aware, Melbourne had an extensive lockdown last year because of the COVID pandemic. So the silver lining of this was it gave us a chance to try telehealth for this group. So we ran a pilot last year, and that was actually facilitated by Liz Mullally and Liz Rand, so two highly experienced LaTCH facilitators through Caulfield Hospital. And we did that over Zoom, and they brought in 4 memory clinic clients, plus 2 of the clients had support people, a spouse and a friend that helped them with, that were part of the group as well. And we did do some pre-screening. So we really did actually highly select the people that were involved in the pilot to make sure that they were familiar and had access to the technology, would be suitable for a group and had a reasonable, didn't have too severe cognitive impairment. So quickly findings. It was a feasible and acceptable. We got our 4 people recruited. We didn't have to make too many adaptations to LaTCH. Everybody attended all the sessions and did the evaluations and found it quite good. And did it work? Did it give us the same sort of results as when we've seen a face-to-face group? And basically the answer was yes. We did a very brief sort of evaluation. I'm only reporting a few of the measures today. But the things we were a bit worried about was sometimes we see these qualitative changes in terms of what we think that the group process makes a difference to with people about not feeling alone anymore, reducing the stigma about memory problems and improving their confidence. And you can see here from some of the comments that all of these sorts of things were changed even in the telehealth version of the group. People also rated their goals. They rated goals before and after the group, and their average contentment in their goals overall improved with the group. So we felt like it worked, and we were quite happy with that. Some of the key learnings from our telehealth pilot were, things you might want to set up beforehand. So some of these things we did and some of these things we thought about later. But we think we did a careful selection of participants, and we think that's really important to make sure you get people who will actually be able to benefit from the group in this, this setting. It's a good idea to do a practice session with technology beforehand, although we all know glitches can still occur on the day, no matter how well you've been set up. Having handouts for people ahead of time, showing them where the different functions they might want to use are, such as the mute button, and turning on or off the video might be useful as well. We did use a separate tech support person, that was actually me in the pilot, who was separate to the main facilitators, and that was a really important part. So the facilitators could continue running the group while some of the participants might have been having tech support issues, and they could have been worked out, their access and getting online and so forth without disrupting the whole group. The support people seemed to still be helpful for those that were having a bit of issues with the technology use, but they weren't as much a participant in the group as they are when we run face-to-face groups. as I said before, we only needed minor adaptations to run the group over Zoom. One of the limitations we found was there were still pretty small numbers. So we had, as I said, 4 participants and 2 sort of support people. And we felt that 4 to 6 was probably the maximum from an interactive group like LaTCH. You know, this is still a pretty high. We had 2 facilitators, 2 clinicians from Caulfield Hospital. There was a tech support person involved. So the cost effectiveness of this kind of thing, you know, still probably needs to be looked at a little bit, and is one of the limitations. So then I wanted to move on and spend the rest of the time talking a little bit about OPTIMISE. So this was our online learning that we also developed last year. And it was, you know, developed to address some of these issues about, so it's asynchronous learning this way. So it addresses some of the issues about having facilitators available and about having people available at the same time. So we ran the pilot last year as a free online course, very similar sort of structure to LaTCH. You know, it was there were 6 modules. They were supposed to be about 2 hours content per week. They had 8 weeks to complete it. You can see the trial registration there, and the protocol has been published if you want to have a further look. And so the content you can see is similar to LaTCH. We had some of the core components of effective interventions. So we used compensatory strategies rather than restorative approach, so similar to LaTCH. Again, psychoeducation, models of memory and how memory changes as you age. We went through and did practical skill building. We had opportunities, so we had discussion boards and gave people an opportunity to share their experiences with their peers. We also had a personalised approach there. Oh yeah, and just quickly, just to show you sort of the topics, but you can see these are similar to LaTCH. Again, you know, we cover names, we cover prospective memory, we cover remembering things we want or need to do, that sort of thing. And of course, with OPTIMISE, because we're online instead of in a face-to-face group, we had all sorts of different ways of presenting the information. And so we tried to really use the interactive, make it as interactive as possible and use lots of different ways of learning information for people to get the different techniques. So the pilot study, these were our inclusion and exclusion criteria. Basically, it was older adults 60 and above who felt that there was changes in their memory and thinking in the last 10 years. They had to be able to speak English and read English to take part and be available during the time period. And they were self-excluded with diagnoses of dementia or psychiatric or neurological issues. So this is feasibility. So I've just highlighted in yellow, I guess, the main numbers to look at. We were actually quite pleased with this. We were aiming for 150 people to start the program to give us for our power analysis. You can see we had 630 people a bit over 630 people who completed the screening. And there was a great demand for this. In about 3 or 4 days, we had 150 people signed up and we had about 300 people, I think within a week. So over the 4-week periods, we had 633 through screening. You can see you do actually need to get quite a few people at the start because they drop off as you get closer and closer to the course. We actually had, so there was 357 complete our baseline questionnaires and we had 312 actually started the program. And of that, about 150 completed it. So we got our 150 completing. And if you look at reasons for attrition, so some of these are about technology kind of issues, but other issues are things that you would also get in a face-to-face group, you know, so people came, the group wasn't what they expected, they're already using all the strategies, or I like this one, you know, it was too much like still being at work, someone said. And then, of course, you get external factors, so that, you know, things are going on in the family that means that they can no longer do the intervention when they thought they would have been able to. Just to give you an idea of who completed this pilot, it is a bit of a skewed sample. We weren't that particular with our recruitment. We just wanted to get the pilot happening. But you can see there in the early 70s on average, we do have more women than men, about 80% women. They're very highly educated. Lots of them had postgraduate degrees, and they're not particularly culturally diverse, the people who did this. So most of them were born in Australia. Almost everybody speaks English at home. They do have high levels of computer experience, although not so high on online learning. So just keeping that in mind that, you know, what we found with these people might not apply to everybody. Oh yeah, so here's a map of Australia just to let you know where it was. You know, the pilot, we just focused on Australia. Of course, this could be rolled out worldwide. The main thing here, we've got people from all the states around Australia, but about 75% of people in metro regions. And then this is just looking at acceptability. So it was acceptable to people. Our main measure of that was the one highlighted in yellow there. So you can see this measure of I would recommend OPTIMISE to others. 97% of people either agreed or strongly agreed with that statement. If you look at some of the other numbers there too, it was highly acceptable. People enjoyed the program. Did it work? So just a quick look at efficacy. So this is on the MMQ, multifactorial memory questionnaire. This is people self-rating their ability, so the memory mistakes they made in life in the last 2 weeks, their strategy use over the last 2 weeks, and their satisfaction or contentment with memory. And you can see with all those measures that before and after the course, we saw an improvement in all these measures. You know, this wasn't an RCT, so we only have pre-post measures for now, but it's good evidence that it is helping people in some way. And in terms of goals, so this is similar to what we saw in the LaTCH telehealth. So people rated up to 3 goals. They rated their current sort of contentment out of 10, 10 being completely content, 0 or 1 being not content at all. So before the group, people were on average had a rating of 4 of their contentment with their memory goals, and afterwards that had improved to 7. So it did seem to be meeting personal goals. We also did some qualitative analysis. So this was a very brief content and analysis when we asked people what the most significant change was. But you can see here, you know, we're getting things like that. We're using more strategies. They felt like there were improvements in their memory in daily life. But one that we were pleased to see, we weren't sure whether in this asynchronous setting where people didn't have other peers, you know, there to talk to, we didn't know whether the discussion groups would work as well to help reduce this concern about memory and help normalise memory. But we found that lots of people said that it did. They really felt by the end of the course that they knew that their types of memory problems weren't an indicator of dementia, and that made them feel much more confident about their memory. So that was great to see. And some other themes that we maybe didn't particularly expect that we weren't targeting with the aims of the research was that we saw people were more confident about their memory. And another one that was really interesting was that people were sharing what they learned in the course, and they were also doing a bit of shame busting. So a few people talked about challenging some ageist comments that they heard in their groups and things about memory, and were challenging age stereotypes, which was nice to hear. So that was a very brief run through our 2 pilot studies that we ran last year. But I guess in conclusion, I just wanted to say that we've now got some evidence that both the telehealth and the online models do seem to be feasible, acceptable and effective ways of running cognitive interventions for older adults, at least those with cognitive concerns or mild cognitive impairment. These ways of running things do seem to give us some wider access to these interventions than people would otherwise be able to have. But of course, there's some caveats around not all clients may be able to access it. You know, our groups that we recruited were fairly highly educated and had good access to computers and that sort of thing anyway. So, you know, there might need to be extra training for other people to be able to have the same access to these kinds of interventions. And I suppose the other thought that I just want to leave with, and I think where we're going now, is about how do we do implementation of these cognitive interventions? You know, are these the sorts of things that fit into health services? And although I think maybe the telehealth group might, something like an online memory course does not necessarily fit with your health services quite so well, and might fit a bit better with community services or something like that. References if anyone is interested, and I will let Wendy take the floor.
Thanks very much, Kerryn. I'll just share my screen now, and thank you for the opportunity to talk today. Thanks so much. I'm going to talk about the Bright Your project. I'm a clinical neuropsychologist based in Melbourne, Victoria, and we managed to get funding to trial an innovative telehealth project called Bridging Gaps in Health using telepsychiatry for young onset dementia. It was myself and Dr. Sarah Farron, who's a psychiatrist, that led this project. And Rene will be talking about some of the other findings in a couple of minutes' time. Sorry, Dana, I can't move my slides forward. Can you pause again? Neuropsychiatry is a statewide service, and we have an 8-bed inpatient unit and run a variety of outpatient clinics, and we're a multidisciplinary team. And about half our work is seeing people with young onset dementia under the age of 65. And because a lot of our clients were rural, we decided to see whether we could set up a telehealth service to make it easier for them to come to appointments, and also to reduce the delay to diagnosis. And because we see people across Australia and Victoria, they were usually driving between 180 kilometres one way to see us. So we tried to see whether we could start increasing our telehealth uptake. So at the beginning of the project, only about 3% of the people we saw were seen via telehealth. and then about a quarter at the end of the project. And then of course there was COVID, where we had to transfer our clinics to telehealth overnight and turn a lot of our inpatient wards to virtual wards. So you can just see how difficult it can be to travel in Australia, just how far it is. We partnered with a variety of different people. So we partnered with what we call memory clinics here in Australia, 3 different rural memory clinics, an urban memory clinic, and also Dementia Australia and Huntington's Victoria, which are the support agencies for dementia and Huntington's disease in Australia. So our goal was to run an innovative telehealth project designed to improve access to diagnosis and care for those with possible young onset dementia, while reducing costs associated with accessing specialist clinics. And so we offered a variety of different things. In Australia, not many people had been doing cognitive assessments or neuropsychology assessments via telehealth prior to COVID. So we spoke to Rene Stolwyk, who's going to talk later about how to do this, and he'd done that in a stroke population. So we wanted to see whether it was feasible to do that with people with possible young onset dementia. So we offered neuropsychiatric assessment and neuropsychological assessment via telehealth, with a hub and spoke model where we had a clinician at one site and then a patient at a rural site with a helper on site, but also in people's homes, and also provided second opinions, attendance at multidisciplinary team meetings. We did a variety of educational seminars talking about genetics and neuroimaging to people that were living rurally, and also to clinicians that were living rurally to try and upskill them. And we often had feedbacks after the diagnostic process had been done with the client, with their GP in their local area. So we looked at a variety of different things to see if the project was going to be successful, and it was run over a 2-year period, and we were finishing up just as COVID started. So we looked at the number of people we saw, DNAs, the number of specialist people saw prior to coming to the service, and also diagnostic delay. And we had a control group and then people that had the telehealth service. Looked at kilometres saved and CO2 emissions, and also at productivity and opportunity costs, which is looking at how much does it save people in terms of transport, in terms of time off work, having to take sick leave, having to put children in childcare to attend appointments. We looked at capability building in terms of how much did people learn from the education via telehealth. These are for clinicians. And then also looking at patient and carer burden using the DAS and HUQOLs and getting QALYs to look at quality of life years and use the Zarat burden. So you can see here, we saw a whole variety of people. Mainly it was Alzheimer's disease, and then mild cognitive impairment was probably the second most common type of condition we saw. But we also saw a variety of rare dementias such as corticobasal or dementia with Lewy bodies, vascular dementia, but also functional neurological disorders and psychosis and anxiety, depression. So what did we find? So we saw 72 unique patients and had 186 appointments. And probably about 60% of them had neuropsychology assessment, and DNAs was very low. What we found was that the time to diagnosis was reduced by about half. So for the control group, it was about 64 months, so about 5 years delay to diagnosis. But for the telehealth group, it was only about 30 months, about 2.5 years. So running a telehealth service dramatically reduced the delay to diagnosis for rural people. And then I'm going to talk about just telehealth tips and dementia care. So as we were running a project prior to COVID, when COVID happened, we were asked across the hospital to help people quickly convert their clinics to telehealth clinics, but also across Australia and across the world, because this hadn't been done very often before. So our main goal in terms of memory clinics during COVID was the ultimate goal was to keep people safe and well. And a lot of people were asking, well, should we still continue with diagnostic assessments during this period, and hoping that COVID wouldn't go on for very long. But as we realised, as COVID continued and we had such a long lockdown in Melbourne, we had to return to business as usual as best we could, using a telehealth platform to prevent infection. We also wanted to prevent people being admitted to hospitals so they weren't at risk of getting COVID, prevent delirium, prevent significant BPSD with clients with dementia in the community, and also assist the at-risk families that there may have been family violence, abuse, neglect, or people at risk of losing their employment or accommodation. So we really were trying to continue to provide a useful service. And often we'd just call the family, and say, look, what are your top 3 things that are concerning you at the moment, and how can we possibly help you? It's a lot of problem solving and brainstorming. We managed to quite quickly publish and do quite a lot of webinars to help memory clinics across Australia continue to provide services for people during this time. I'm now going to talk just briefly about some of the tips that we learned, and Rene will talk about some of the change management things as we go along. So prior to the appointment, when you're seeing someone via telehealth, it's always very important to know where will the person be seen. Will it be at their home? Will it be a GP clinic? We always call the client and their family prior to obtain consent and to tell them that it will be a telehealth appointment and explain what's going to happen. For a number of these people, they've never used telehealth before, and it's quite anxiety provoking. So being able to talk them through and exactly explain the process is very helpful. We always do a tech call prior to make sure that the technology is working. So on the day of the appointment, you're not running behind because they can't actually get or log on. And also educate the support person. So for cognitive assessment, often we would use a family member or a care partner to assist with some tasks, such as paper and pencil tasks, and we may have to email them tasks or send them in the post. So you need to educate the person prior. When the appointment actually comes around, we always explain what the backup plan is if the technology breaks down in the first couple of minutes. And this reassures people a lot that you have their phone number and you have their contact details, and explain, for example, that if you had 2 to 3 glitches, then you might just call them over the phone so they have a bit more control about the appointment. And make sure that you've got all the details and also the location of the patient at the time of the assessment. So even though you may have their address on the medical record, make sure you're checking where they're actually located, because they may be at their daughter or son's house. And that's very important just in terms of risk if something happens and you need to get in contact with them quickly. Make sure you check the sound and vision. And if you use some platforms, you're actually able to adjust the bandwidth. So if it's a poor connection to an area where it's got very poor Wi-Fi or broadband, that you may be able to reduce the quality of the picture, but it makes the sound much more consistent, which will mean you'll be able to do the assessment properly. Make sure you position the camera so you're looking at it, so it feels much more real for the person. And then just continue with the appointment just like you would any other appointment. I always make sure that I try and naturalize and make sure that the person that's being seen via telehealth feels less anxious. And I think if you're not used to using telehealth, often the clinician's so anxious, therefore the client and their family feel anxious because they feel like the clinician doesn't know what's going on. So make sure you do all of the natural things that you would do in a normal appointment, such as spend time introducing yourself, explaining what your position is, explaining where you are, and explaining who's in the room with you and who's out of view. And make sure that you tell the family that it's a confidential session and that it adheres to normal privacy laws, and even use the camera to show around the room so they can see who's in the room with you, and also get them to do the same so you know who's in the room with them. Explain the purpose and structure of the appointment, and then also set expectations. So the appointment may go for an hour and a half. We'll have a break in between where you can go to the bathroom or have a coffee, just like you would face to face. And check what their understanding is of the purpose of the appointment and try and make some goals together so you develop the rapport quickly with the client and they feel that they're involved in the care. So when you're using telehealth, you do need to adapt your therapeutic skills somewhat. And obviously framing your face and head and shoulders in view is good. But for some sessions, for example, a therapy session, you may want to even sit further back from the camera. So it would be like you're sitting in a chair like you would in a normal therapy session. It's important that you're quite animated because it is harder to pick up on the non-verbal cues. So make sure that you smile or you frown and that your voice is clear and animated and not monotone. And make sure your body language mirrors what you're trying to express. If you want to show empathy, sometimes you can kind of lean forward to camera like this, or if you want to have a bit more distance, you can obviously go back. It does require a higher level of attention for both the clinician and the client, so it's important, therefore, that you allow enough time for breaks if you need to. And once you're comfortable with telehealth, I think it's always good to try and minimise your on-screen image, so you're not looking at yourself and the client together, because I do think that's quite distracting, and it's much more useful to be able to just look at the client themselves. In terms of building rapport, I think a reassurance of physical privacy is really important. But when you look at telehealth studies, one of the main things that clients and families complain about is that it feels rushed because the clinician's trying to feels anxious themselves and trying to rush themselves through. So make sure you're familiar with the platform, because your anxiety impacts the rapport building. And be explicit. If you're having difficulties reading the client's body language, or you're worried that they're concerned or upset, ask them and get them to tell you a little bit about how they're feeling. And be mindful also that the client may reveal more detailed personal information than face-to-face. And so you have to be a bit more careful of boundaries, because in a lot of the research about telehealth, it is shown to be much more informal medium where the power differential is very similar. So rather than like it's a clinician and the client, it's much more like this. So you need to be careful when you're talking about boundaries. And because we often try and check in with the client as we go through, because it's quite a novel medium for them, and they may feel anxious and they wouldn't necessarily tell you if they can't hear you clearly, or they can't see you, or they didn't understand. So your role as a clinician is to contain their anxiety, not to add to it. These are some of the in-home assessment tools that you can consider. There's a whole range of different cognitive assessment tools and also cognitive screening tools, such as the MOCA, that have now been adjusted to a telehealth medium. And some of the guidelines that we've published will talk about these. If you're seeing clients with hearing impairment, it's very important to do a test call prior, just to see what their test call is like and their hearing is like, and ensure that the client's wearing hearing aids, and turn the speaker volume up both at your end and at their end. And you can also use the headset to minimize feedback if you need to. And really make sure that you're looking at the camera, because a lot of clients lip read as well. So it's important that they get a very good visual of your mouth. For clients with low vision, we see people that have posterior cortical atrophy, where they have a lot of visual difficulties. And therefore, it's really important that they have someone, a care partner or a family member at the other end to facilitate the assessment. Because then that person can orientate the client to the work desk, the technology and the stimuli. And if they're completely blind, it's still very important to be able to see the client. So I'd still use a telehealth medium, but you may need to rely more on OT assessment. For people with communication difficulties, I think we always allow extra time, and make sure that you reduce distractions and have a quiet environment, and use other mediums if they're having difficulties with communicating, such as a chat or a whiteboard or screen share tools. So if someone can't understand what you're saying, you can obviously chat in the chat function, or even use the whiteboard to actually type out what you've said and they can type back. We often do joint sessions together with a speech pathologist to make it a lot easier for them. With interpreters, it's quite tricky working with interpreters over telehealth. It can be done. We often use phone interpreting or tele-interpreting. We often find it's best if you have the interpreter with you, if that's possible, and then the client just by themselves or with a care partner at the other end. Or you can use tele-interpreting with 3 people on the screen. But it does take a lot of practice, and you have to make sure you spend the time educating the interpreter about what's going to happen and how they can look at the client's language and the client's cognitive functioning, so they're able to tell you that after the time. For clients with cognitive impairment, we've found that really people with mild to moderate cognitive impairment can still use a telehealth medium quite well, but it's always good to do some cognitive screening prior, just to make sure that the person will be able to use a telehealth medium. And you may need a support person and allow more time with virtual breaks. For clients with behavioural change, we've done quite a lot of behaviour management with clients via telehealth, but you do need a support person, and that's really critical at the other end. You need to make sure you assess the acuity and risks quite carefully, and make sure that you involve the support people when developing recommendations. The great thing about telehealth is you can actually get a view of the environmental setup at someone's home or someone's care facility, so it can help you develop the positive behaviour support plans, and it's easier to schedule monitoring sessions. So what clinical skills do you need to be good at telehealth? I think a patient in calm demeanour and being unflappable, particularly if there's technology problems, which there often are. Well-developed social skills. It's really just like seeing a client in person. And I think a lot of clinicians just need to rip the Band-Aid off and try it to see actually that it's really not very difficult. I think you really need the trust and respect of your clients and family very quickly. And need to be problem solver and solution focused and flexible. And are aware of cultural and social issues in the local community that you're providing the service to. These are the TeleNeuropsychology guidelines that we've developed that we're happy to send to people once they're published. And these are some of the recommendations and useful links. Thanks so much.
Cool.
Thanks so much, Wendy, and hi everyone. Yes, my name's Rene Stolwyk, and today I'll be really following on from Wendy, who really nicely described in the start of, in the first part of her talk, around that Bright Dog service. And what was very clear from her evaluation was just how feasible and how successful that service has been in terms of opening access to quality services for people with young onset dementia in rural areas. In terms of that, that's the overall data, and it's overwhelmingly a positive experience. But within that, certain sites maybe responded to telehealth more than others. And what we found was that different sites tend to experience different kind of challenges, barriers across those different sites. So as part of the evaluation for Bright Dog, we also conducted a qualitative study, really looking at evaluating the clinician's experience, both pre and post implementation of that Bright Dog service, really trying to understand from a change management point of view, from a service implementation point of view, what are the barriers and facilitators to a good telehealth service. And this evaluation, particularly this aspect of it, has been led by Wendy and I's PhD student, Amy Brown. So I'd really like to acknowledge her and the huge amount of work she's put into this. I'm really just presenting on her behalf today. I'm actually not going to go through much of these background slides because Wendy did such a good job, other than, I guess, to say that younger onset dementia services are incredibly helpful to improve or to reduce diagnostic delay, particularly for those people with access issues in rural areas. And we understand how important it is to have that specialised multidisciplinary service in terms of improving quality of services. And so, in terms of those barriers, obviously geographical location is one of them, but also even within urban areas, a number of clients may have mobility issues and community access issues, which impacts on their ability to access healthcare. And as we're all very much aware, telehealth has shown to be incredibly helpful during global pandemics. However, this project, as Wendy explained, really did begin before COVID-19, and we were really looking at this telehealth modality through the lens of rural health to improve services in those rural areas. I won't go through too much describing YOD as again. Wendy did such a great job with that. And I guess just the point here, there are a number of factors that previous research has looked at in terms of barriers and facilitators to telehealth services. And one of those that's come out quite consistently is that clinician acceptance, the acceptability from a clinician point of view. Of course, from a client-patient perspective, very important, but the clinician aspect is incredibly important as well, and that's what we'll be focusing on today. And I guess another unique aspect of this study, a number of studies looking at telehealth has really looked at it at an assessment point of view. So whether clinicians or clients were, accepted and what the experience of was around just at an assessment, individual assessment level. Whereas this project is really looking at that broader level, at a service level, both pre and post implementation. So we'll get the opportunity to look at how clinicians' attitudes and experiences actually change as you go through a service implementation. So the participants in this study was a convenient sample of clinicians involved with the Bright Dog project. Both provider clinicians, who are predominantly neuropsychiatrists and neuropsychologists providing telehealth services over telehealth, recruited from the Royal Melbourne Hospital Neuropsychiatry Unit. Whereas the receiver clinicians in the rural areas were, as you'll see a little bit later, were from a number of different disciplines, and they were the teams in those rural hospitals receiving the Bright Dog services. In terms of our procedure and data analysis, what I'll be focusing on today is our group interviews, which followed a semi-structured interview guide and explored a range of domains from clinician experience, using the telehealth services, perceived benefits and concerns around the service, and the impact on their patients and the healthcare service more generally. We used a qualitative approach, including thematic analysis for our analysis. We also included some questionnaires for a more kind of mixed method approach to this project, but in the time I've got today, I'll just be sticking to the qualitative findings. In terms of the clinicians, yeah, as I mentioned before, 23 clinicians. In terms of the provider clinicians, predominantly neuropsychologists and neuropsychiatrists. And in terms of the receiving clinicians in those rural areas, a range of different multidisciplinary disciplines were involved. So in terms of the qualitative analysis, we went through the process of the interviews, transcription, coding, and right through to using a team approach to engage in thematic analysis. And this is an overview of the number of themes that came out from the study. And just to orientate you to, it was quite obviously a large qualitative study across time. So a number of themes emerged from our pre-implementation stage. So this is really before or in the very early stages of Bright Yacht implementation. And hopefully you can see my cursor there. These are a number of themes came out. And they really reflected themes where the clinicians were talking about pre-service considerations, so even before the service would start, what they were kind of expecting during the service, and also those long-term outcomes. Then if you look down the bottom of this page, these are the themes that came out post-implementation. So in the late stages, or actually the closing of our of the implementation period, and you can see a range of themes came out. And then just, to make life interesting, we had the impact of COVID, which is unexpected, but a number of things came out during that post-implementation, those post-implementation interviews. So I'll discuss those as well. And again, with those post-implementation interviews, again, those 3 stages of pre, during, and post-implementation times came through. So maybe just starting with looking at those pre-implementation things. So prior to implementation, what were some of the attitudes and perceived potential barriers and facilitators to implementation? Thinking about pre-service considerations, I guess the main thing that came up around those pre-service considerations was really around clinical need. And the main clinical needs, I guess, that the clinicians were, particularly the rural clinicians, were highlighting were just the need for improved patient access, both in terms of accessing a service, but also reducing the travel time as well. It was interesting that it was from a patient perspective, but actually the clinicians themselves highlighted a clinical need in terms of many of the clinicians in these rural areas are more generalist in their training and fairly junior. And so they were really looking forward and express needs around upskilling, both in terms of diagnostic skills, but also management skills as well. It was also quite striking how different the clinicians were, both within sites and across sites, in terms of their previous experience of telehealth. Some had some, I guess the first one of call is overall experience was low, but some people had early kind of positive experiences, where others had some really negative experiences and had a number of concerns based on them. So what was obvious quite early on was that people were coming in with very different attitudes, either positive or negative. That's something worth accommodating. Thinking about what they might be expecting kind of during implementation, a number of concerns came out around telehealth barriers. One of those concerns, particularly thinking about the rural aspect, people were very concerned about people being in those rural areas not having access to the internet, and that being a massive barrier to whether the service was going to work. Another major concern was, from a clinician point of view, really concerned about whether they would actually be able to provide services over telehealth. So, for example, can you provide cognitive assessments and psychometric assessment over telehealth? And can you provide actually clinical examinations, neurological examinations over telehealth? So would there be significant barriers, and would that impact on quality of care? In terms of thinking about more long-term expectations around and particularly around the clinical outcomes of the service, I guess one of the issues that was noted relating to the outcomes for clinicians was actually a concern about a potential de-skilling of the rural workforce. Would telehealth take over their skills, and would they be ending up with patients forced to only have telehealth services and be reliant on metro clinicians? In terms of outcomes for patients, again, most of it was expecting really positive outcomes, both in terms of reduced travel and improved access. And a number of clinicians noted an opportunity for a shared care type approach. So maybe avoiding the issues of rural clinicians being redundant, to actually have an approach where they're able to access the expertise from the metro teams, but also provide some services themselves where they feel comfortable, and maybe some mentoring going on. So a bit of a shared hybrid approach. So those were the themes that came up pre-implementation. So or very early in the implementation of BrightGold. Let's move a number of months forward now and actually look at what were the themes identified post-implementation. Were there many changes? And did the attitudes kind of change? And what was interesting, some things did change, some things didn't. Clinical need was one of the themes that actually remained fairly consistent. And there was, I guess, a reflection that, yes, overall, the BrightGold was really successful in terms of addressing a number of clinical needs. And those sites that had very clear clinical needs, both around understanding the need for improved access and reduced travel for their clients, but also those clinicians who really identified in themselves that they wanted to upskill in their skills, very much facilitate engagement with the BrightGold project. There were still some concerns in terms of telehealth about that de-skilling of the rural workforce and that redundancy. That was still mentioned by some clinicians. What a major theme that came out though was this issue around clinical relationships and the importance of very early on, so during that pre-implementation phase, of spending time building the relationships up, particularly between the provider and the receiver clinicians. Because not only are you introducing a new service, often you're introducing new disciplines, and some of the rural clinicians may not have worked with a neuropsychologist before, may not have worked with a neuropsychiatrist before. So spending time engaging and building those relationships and that trust and that working alliance was noted as a great facilitator. Also identifying the champions, both the provider and the rural sites, was considered really important. So having a champion at that provider site, really helping and skilling and supporting clinicians providing services to those rural hospitals, but also identifying who in those rural hospitals were more likely to engage with telehealth and would act as those as the clinical champions and bring their teams along, was noted as a significant facilitator. Moving on now to during factors within the implementation. The importance of adequate resourcing was highlighted as a significant theme. So particularly around providing administrative support, which I think a lot of people may not really think about right from the start. I think a lot of the ideas around setting up the hardware, the software, comes to mind first, but the importance of administration to set up appointments and help with setting up sessions and supporting the clients. And there is quite a significant amount of administrative support that can really help facilitate success if built into the telehealth model early. Clinicians also talked about changes to clinical practice. And many of those Wendy's covered already. So the importance of taking that time to build rapport, making sure that you've really thought about the ethical considerations and ensuring that, particularly if you're doing at-home assessments, that you've got adequate boundaries in place. Sometimes if people are receiving services from home, they can get a little bit more casual, but it's really important to make sure that you're setting up these sessions so that you're ensuring the reliability and the validity and the kind of the ethical practice around your assessments. The importance of patient suitability came out as well as a major theme, really taking the time to strategically think about who, and on a case-by-case basis, whether the client is going to be suitable. Because if you do a one-size-fits-all approach and assume everyone's going to be suitable, you're going to end up having some cases where you don't experience success, and that can erode confidence within the service. So the suggestion of having assessments around suitability early on, and also acknowledging client preference or patient preference as well. They might be suitable for telehealth, but really strongly don't want to engage, and we need to respect that as well. And the final during service factor was technology, and it was very much the feedback we got was technology is a fundamental aspect. If you don't have quality hardware and software and reliability in terms of the telehealth service, that can significantly erode confidence very early on and engage in and result in disengagement from the services. People learn not to trust it. So it's really important. It's really hard in those early stages, adapting all your clinical skills, as Wendy mentioned. And if you've got disruptions to the audio and the video and cutouts and things like that, it really can cause issues. So getting the tech right, lots of setup and practice, and getting that all sorted with adequate training was really important. And just finally, moving on to the outcomes post-service. Again, the theme of service quality came up, both limitations to service quality in terms of obviously there were some clients where telehealth wasn't suitable, but also overwhelmingly in terms of improved clinical services, both in terms of reduced travel time for their clients, receiving more accurate and early diagnosis around young onset dementia, and receiving the help around management as well. In terms of the way of the future, just finishing up around that, a main theme was really around that. Although the telehealth service was appropriate and was suitable for for the majority of the clients, it's not for all. So again, going and assessing patient suitability is important. And the idea of that shared care model, so accessing the expertise from the Metro team alongside with providing local services. So having a bit of a hybrid approach was proposed by a number of clinicians as potentially the way of the future as well. And just finally, just that impact of COVID was really interesting. It was an unforeseen aspect, but very rarely, I guess, does COVID have any some positive aspects. But it was noted that COVID really did help with uptake of telehealth in a lot of these rural hospitals, as generally there was a lot of support to upskill and provide the infrastructure required for telehealth. And it also helped some clinicians who are involved in the Bright Yard team really provide support, because we had a bit of a head start with telehealth. So they were better placed to provide support for clinicians that had to very quickly adapt to telehealth. So look, just very, very quickly, I guess what this implementation study has done is it's really provided really helpful information about how to maximize a successful implementation of a telehealth service, highlighted a number of barriers and facilitators that can help facilitate acceptance and sustainability of a telehealth service. And as we move through to a post-COVID world, I guess, I think these projects, this information will be incredibly helpful, particularly as we start to more strategically think about the future of telehealth. There will be, I think, a snapback to usual practice and non-telehealth services in a post-COVID world, and we're seeing that already in Australia. But there will be situations or contexts where telehealth, I think, does have a future, particularly in the rural context, particularly for those with community mobility issues. And I think the expectation from clients may be that we can offer telehealth according to their preference. So we're hoping that these findings will be helpful from that perspective. So I will finish there. Thanks very much.
Thank you so much, Rene. And I might get you to stop sharing your slides so we can see everyone, because we're going to have a bit of a Q&A now. Just want to say thanks to you all for fabulous presentations, and yeah, so excellent that all of you have been a bit ahead of the curve and well prepared for COVID in all the really important work that you've done in telehealth and on a remote assessment and management, and being there to guide practice through this kind of really uncertain time is a really valuable role that you've all served. So thank you. So I guess when I was listening to you talk, my work in telehealth, as you know, has been in stroke mainly and acquired brain injury. But I noticed a really common pattern across different, implementations of telehealth, in that clinician uptake and attitudes towards telehealth and online modalities for both assessment and intervention seems to follow this common pattern where there's this initial reluctance followed by an acceptance that comes with having experienced it. And so I just wondered your views on what you think the main reasons are for both that initial reluctance and then that subsequent acceptance. Maybe Wendy, do you want to talk about that from a clinician point of view?
Yeah, sure, Dana. Can you hear me well?
Yes.
I think initial reluctance is a change to practice. I think people often are trained a certain way and that they've had no training at university or in their workplace about how to do telehealth. And so I think that's a real barrier to get over, that I think it will have to be part of the training program, and also to get some modules about how to do it in people's workplaces. I think fear and anxiety, we particularly noticed that in the pandemic, when you're asking people to change their practice overnight under, a background of great fear and anxiety and loss of control, was really difficult. And they were having to do something that they didn't necessarily want to do straight away, rip the Band-Aid off and have to get in there. I think in dementia care, particularly also diagnosis. So is the diagnosis the same quality as what you would get if you saw someone face to face? And a lot of people, before they do telehealth, don't believe that you can get the same connection or develop the same level of rapport with someone via a screen. And once you start doing telehealth, you realise you absolutely can, that you just need to do it a slightly different way and get confident yourself that you can relax in it, that you can develop the same rapport and the same quality of care. Thanks, Dana.
Great, thanks, Wendy. Do either Kerryn or Rene have anything to add to that? Oh, you're muted, Kerryn.
I could hear Wendy. I could hear Kerryn.
Oh, could you? Oh, that was just me then.
Can you hear me now?
Yeah, now I can. Yeah.
All right. I was going to say not really. Like I thought about the question beforehand, and Wendy sort of said everything I was thinking about. That I think often people were being asked to take this on during the pandemic, and there was a lot of other stress going on, and it wasn't the right time for everyone to be sort of flexible with their thinking and try new things. And I think, and there's that bit of that concern before you do much of it. Are you going to get the same clinical experience? You're not going to get the same body language cues and things like that, which you don't. But there's other cues and there's other ways that you can still be able to kind of make the same diagnoses and do interventions and things, I think.
Yeah, no, I agree 100% with everything that all of you have said. I was also wondering, now that experience of remote assessment and management in COVID is so much more widespread, do you think it's here to stay? You touched on this a little bit in your presentation, Rene, so I think I know what you're going to say in response to this, but just wondering if you think, if it is here to stay, should it replace in-person services or complement them? And if it is complementing them, how could that best be set up? Rene, do you want to speak to that?
Yeah. Look, I do think it's here to stay. As I mentioned before, I think we are going to snap back, and I think we've seen that in Australia. But I think the tide has turned. It's been, COVID has been this agent of change, and it has thrown people into telehealth, and I think which is a good thing. So I think people are now understand that, I can do it, and it is helpful. And I think we'll go through this process, I think, over the next few months, where we strategically start to understand, well, where does it work best? And I think that's going to be the building blocks, and we can kind of move them from there. And I think, where things were 5 years ago when I started, you couldn't share a screen, you couldn't do group chats like this. So I think now is a brilliant time for people to enter into telehealth, because imagine what we're going to be able to do over telehealth in 5 years' time from now. So I think that's what I'm hopeful for in the future, is is just building our suite of telehealth skills,
Mm.
and finding out. And I think it will become an expectation of clients too, that will start to think, actually, why do I have to travel 3 hours when I could just do a Zoom meeting? You know, I think they're expecting now some clinical change. So yeah, that's what I see for the future.
Yeah, absolutely. Well, on that topic, yeah, what do you hope to see in terms of future developments in this field? You know, I agree that, you know, having some of those technological glitches ironed out would be great, so that we have a much more kind of seamless experience where the amount of training that needs to go into and preparation that needs to go into each appointment for the people on the user end is minimized, so that, you know, for example, we can show assessment tools and intervention kind of materials within the kind of online sort of Zoom or whatever platform, and without, you know, getting people to shift screens or move between different platforms. And yeah, so I wondered what your thoughts were about future developments and where we could be heading next to make sure this is yeah, the best version of itself.
I think I'll be quite off with this one, but just quite passionate about, I think we're also seeing, or potentially will see, some inequity in healthcare around telehealth as well. I think, you know, access, I think to both hardware and software and internet is very much along lines of socioeconomic status. So I'm really concerned about that. And I think the points that came out through our project too around potential de-skilling in rural areas. So moving everything to telehealth and having urban clinicians treat rural patients, I think, is a potential problem as well. So those two, if we could address both those two things, access to assistive technologies and thinking about that shared model in rural areas, I think are two really important factors to consider.
So would that mean maybe like a telehealth hub at a GP clinic or a community health centre or something like that, where people don't have the technology or the internet access at home, they can still engage in these kind of services and appointments?
Absolutely. Yeah, absolutely.
Right. Wendy.
Dana, we really noticed, particularly because we work in psychiatry, a lot of our clients with chronic mental illness, such as schizophrenia and bipolar, they were lucky to have a mobile phone. So we often had to get them into clinic during COVID, but in a separate room, just so they could access their usual care. But we're seeing now, you know, a year of people not attending any medical appointments at a general hospital and the ramifications of that because they were too scared to come in. And I think our patients now that they know that we can do telehealth, they're demanding that they get a telehealth service. They're refusing to drive for 4 hours for a 45-minute review and wait for, you know, a couple of hours for an outpatient clinician to see them. They're like, well, if you could do it during COVID, you can do it now. So I think we will have to change as clinicians, even if people are somewhat reluctant.
Yeah, Kerryn, what do you want to see in the future for this field?
Yeah, well, look, I mean, I think it's kind of exciting because I think it does break down some of the access barriers. And even though I agree with Rene, we've got to keep an eye on the socioeconomic sort of barriers. It can break down some of those travel and distance barriers, and maybe with some training and with some supports, like you're suggesting with these central hubs and things like that, maybe we can break down some of those other barriers where some of those people probably had difficulty getting into the hospital to have appointments and things as well. So yeah, so I think it's kind of an exciting place to be, and you know, one of the silver linings about last year.
Yeah, absolutely agree that, you know, just I've noticed that people who are joining in telehealth appointments now, you know, there's much more experience out there, so they kind of know already a little bit what to expect, and it's not so new. They're often coming in with a little bit more background experience in how to use Zoom and that sort of thing. Yeah.
I think, Dana, as well, thinking of professional development, we're sort of part of an atypical dementia sort of educational group, and it was face-to-face, and now it's via, you know, Zoom or telehealth, which means you get 200 people from around Australia accessing specialist professional development. You know, people living in very rural areas that are providing services to people locally that they could have never have come to Melbourne to attend that group in the past. So, and I think that the worry about de-skilling rural clinicians will only happen if we let it. And I think the opportunities to work together collaboratively is so huge with telehealth that really we've found that we get more referrals, but there's much more we're learning from people in rural areas and vice versa. And really, if you set it up well, it can be a fantastic collaborative experience.
that's a great point. And yeah, I mean, even us doing this presentation for people in Scotland is a great example of that. And, you know, all the online conferences and things that I've been part of in the last year, which normally run face-to-face, have all had, you know, at least double their normal attendance, because being able to offer it online means, you know, those access travel related barriers have been overcome. So yeah, agree, there's lots of potential. Just quickly, just to wrap up, you know, in terms of that future development, you know, I guess, you know, at the moment we're working with things like Zoom or CoView or different telehealth platforms, and maybe with OPTIMISE as well, that kind of online community. What do you see as the role of other types of technologies, maybe like artificial intelligence, robotics, avatars, bots, that sort of thing? Do you think there's scope for including some more kind of technological advancements in our work with people with dementia and other acquired brain conditions? Rene?
Yeah, it's funny, Nick. I think everyone's on a curve in terms of technology acceptability, and from a telehealth point of view, I think I was in the front of the curve, and that I was really eager. I saw the opportunities in rural health. I was an early adopter from that perspective, and I think it's important to make that distinction between telehealth services, which is where you're just providing what would normally be face-to-face services over a telehealth medium, to these other aspects of you know, using technology within clinical practice. And yeah, I think when it comes to those aspects, and again, I'm probably a classic late adopter. I don't know much about it. I'm concerned. I'm avoidant. That I think that's probably where I'm at with that side of things. But I think engaging in telehealth, I think at least has reduced one barrier to going further. Like I think one aspect that I think that I'm probably looking to next is the opportunities for more remote monitoring. I think that's come out in the last, you know, few months, where now everyone's got a smartphone, and we could be, you know, have the opportunity to be doing more regular remote monitoring from our smartphones to assist with healthcare. So I think that's one opportunity. But yeah, chatbots, I'm not quite there yet. Avatars, I'm not quite there. But who knows what's going to happen in the future, you know?
Yeah, absolutely. Can you see those being part of OPTIMISE, Kerryn?
Look, you know, maybe something like OPTIMISE. I'm sort of thinking about it, I think there needs to be this kind of like a bit of triaging, isn't there, about level of care. So I think for people maybe who are kind of high functioning, who don't have much distress or anything, you know, they just want to know a bit more about how memory works or what's normal aging or some strategies. Well, then maybe some of that could be provided by a chatbot or by online, you know, online sort of things. But I think it's then, you know, looking at the level of patient distress, the level of care needed, that clinician input, then that doesn't seem like at the moment our robotics and avatars and things would be able to replace much of that. But maybe in a screening sense, there could be some role to take off some of those more, early, like, low level distress kind of screening.
Yeah, I mean, it just strikes me that, you know, we all worry a little bit about robots taking over the world and replacing us, but you know, I think that the risk of that in the work that we do is fairly low. But I guess, you know, there's definitely room to think about how we might take advantage and harness some of the technologies to work, you know, with them and alongside them to complement what we do and enhance it. And like you say, remote monitoring or, you know, kind of using artificial intelligence to do some of that kind of calculation that, you know, we sometimes do manually. You know, I guess working together with technology and using it for a good purpose, together with our clinical expertise. I can see lots of opportunities there, and looking forward to seeing where this field develops. So just want to say thank you all for your words of wisdom and your insights into working with telehealth and remote technologies. I think, you know, there's been some really great both insights from the research evaluations that you've done, but also the clinical experience of doing that. And hopefully both clinicians and researchers listening today can get some tips and tricks to guide their practice and their research as well. So thanks again. Anyone want to add any final words?
I'm good.
Yep, great.
Thanks, Dana.
Well, thank you. And yeah, thanks Terry and everyone at the SDRC. Hope you've enjoyed it. See you later.